Yeah, good morning. Morning, colleagues and colleagues. Welcome again today to this another session of our weekly presentation. So today, Dr. Mashor Abimbola will be taking us on what we know as screening for disease, especially screening for eye disease. And with this, at least we should be able to learn more about how to screen for peculiar eye conditions, what it entails, the role of screening, how to accomplish the task. So this is 9:03, and so we'll take the presentation and then about 45 minutes, then we can take question and answers afterwards. So Dr. Masha, please, you can start. Hello, hello.
Yes, we can hear you. We are waiting for Dr. Marsha.
All right, okay.
Mm. Dr. Marsha, I think your speaker is off. You need to put on your speaker.
Oh,
Thank you.
good morning, teachers, senior colleagues, and colleagues. This morning, I shall explain the term screening for disease. The second question is, you have been directed to set up a screening program for diabetic retinopathy in your state or province. Describe how you would accomplish this task. I will begin with the first question. Explain the term screening for disease. Screening refers to the use of simple tests across an apparently healthy population in order to identify individuals who have risk factors or early stages of the disease, but do not yet have symptoms. It is a public health intervention intended to improve the health of a precisely defined population. This is according to the Community Eye Health Journal. Screening is also an anticipated identification of those who may have a problem and may benefit from further investigations and treatment. The United States Commission on Chronic Illness in the year 1951 defined screening as the presumptive identification of unrecognized disease or defect by means of tests, examinations, or other procedures that can be applied rapidly to sort out apparently well persons who probably have a disease from those who probably do not. Screening types include mass screening, selective or high-risk screening, opportunistic screening, and case finding. Screening types could also include monophasic or multiphasic types. Examples of commonly screened eye diseases include cataract, glaucoma, diabetic retinopathy, refractive error, age-related macular degeneration, retinopathy of prematurity, amblyopia, and squint. The aim of screening is as follows: to reduce mortality or morbidity through early detection and treatment, to reduce the severity and improve outcome of a disease condition through early detection and treatment, to enhance lifestyle modification in asymptomatic individuals, and to mainly separate healthy individuals that probably have a disease from those who probably do not, for appropriate management. The uses of screening include case detection, which involves a presumptive identification of unrecognized disease. Examples include rhesus factor to prevent hemolytic disease of newborn, which is usually screened for in the antenatal clinic. Another use of screening is in the control of disease. This involves prospective screening in which people are examined for the benefit of others. An example is in a case where the government could request for screening of immigrants for infectious diseases such as tuberculosis. Another use of screening is in the research purposes. The prevalence and incidence of a disease can be inferred from research. Another use of screening is in educational opportunities. Screening could provide opportunities for creating public awareness and for educating health professionals. Criteria for disease screening. This was stated by Wilson and Jogner, and it was adopted by the World Health Organization in the year 1968. The condition to be screened should be an important health problem. There should be an accepted treatment for patients with recognized disease. Facilities for diagnosis and treatment of such conditions should be available. There should be a latent or early symptomatic phase of this disease condition to be screened. There should be a suitable test and examination. The disease condition should have a test that is acceptable to the population. The natural history of this condition, including development from latent to manifest disease, should be adequately understood. There should be an agreed policy on whom to treat. The course of case finding, including diagnosis, treatment of patient diagnosed, should be economically balanced in relation to possible expenditure on medical care as a whole. Case finding should be a continuous process and not a once and for all project. There are determinants or factors, and here even including questions that should be asked on disease conditions to be screened. Is this disease condition to be screened, is it an important health problem? Considering the magnitude and the severity of the disease condition, the mortality and morbidity of the disease, the consequence of the disease on individual and the community. Is the natural history of this disease well understood? Is there a long term between the presence of risk factors, subclinical disease to overt disease? Does early intervention improve clinical or public health outcome? Is the screening test valid in terms of sensitivity or specificity? Validity is the ability of the disease condition, of the disease detection method to separate those who have the disease from those who do not have the disease. While sensitivity is the ability of the disease detection method to identify correctly those who have the disease as positive. Specificity is the ability of the disease detection method to identify correctly those who have the disease as negative. Is the test simple, safe, reliable, and affordable? Reliability is the consistency of the results if the disease detection method were repeated more than once. Is the test acceptable to patients and staff? In terms of discomfort, risk in which the screening tests may pose to the individuals being screened, and with informed consent given. Other questions about the diagnosis and treatment of this disease to be screened. Are there accessible, readily available, and rapid diagnostic facilities and health personnel for the condition to be screened? Is there an agreed policy on whom to screen, on whom to treat, rather? Is there an acceptable, readily available, effective, and accessible mode of treatment that will influence outcome of the disease? Is it cost effective? Thus, the disease detection should be more economical in comparison to the entire expenditure on medical care. compared to treatment from the coming down with the disease condition. Case finding should be a continuous process, and we must ask if this process is sustainable. Does the benefits of screening this disease outweigh the harm? Now, what are the limitations of screening? Screening cannot offer a guarantee protection against the disease. And there's an issue of false positive results and false negative results that could arise from screening methods. Examples of screening programs include antenatal screening for anemia, blood group, rhesus, hepatitis B virus, retroviral screening, and touches diseases. And then there are adult screening programs, which include mammography and pap smear for cervical carcinoma. Early detection of risk factors or early identification of disease is beneficial for the clinical or public health outcome. This is an important underlying concept in screening. And an effective screening must reach a high proportion of population at risk. The second part of the question reads thus: you have been directed to set up a screening program for diabetic retinopathy in your state or province. Describe how you will accomplish this task. And I'll do this based on the following outline: introduction, epidemiology, requirements for diabetic retinopathy screening program, setting up a screening program for DR, and conclusion. Diabetic retinopathy is a known complication of diabetes mellitus. It is a microangiopathy in which small vessels are vulnerable to damage from hyperglycemia. And this is characterized by varying degrees of microaneurysm, hemorrhage, hard exudates, cotton wool spots, venous changes, and new vessel formation involving the peripheral retina, macula, or both. Diabetes mellitus is a heterogeneous group of metabolic disorders characterized by chronic hyperglycemia due to a defect in insulin secretion, action, or variable combination of both. The International Disease Federation indicated that 537 million people worldwide had diabetes in 2021. In sub-Saharan Africa, Nigeria has the highest number of people living with diabetes mellitus, with a prevalence of 5.77% by Uloko et al. In the year 2018. Diabetic retinopathy is a leading cause of visual loss in the Western countries among working age population. 1/3 have signs of diabetic retinopathy, and of these, a sight-threatening diabetic retinopathy, including diabetic macular edema. Globally, diabetic retinopathy accounts for 5% of all blindness, affecting 2 million people as at 2005 reports given by the World Health Organization. Global prevalence of diabetic retinopathy is about 27% as of 2015 to 2019. Diabetic retinopathy is the leading cause of diabetes in adults between 20 to 70 years in the developed world. This is from the Community Health Journal as at 2003. In 2021, the International Diabetes Federation estimated prevalence of diabetes mellitus in Nigerian adults aged 20 to 79 years to be 3.7%. And Ewuga et al. In their study at the Jos University Teaching Hospital found the prevalence of diabetic retinopathy among diabetics as 18.5% as at 2018. The major risk factors for diabetic retinopathy are long duration of diabetes, poor glycemic control, and and hypertension. Diabetic retinopathy is the most common ocular complication of diabetes. Diabetes Control and Complication Trial and the United Kingdom Prospective Diabetes Study showed a strong correlation between hyperglycemia and the development of diabetic retinopathy. The most common cause of visual loss in diabetic retinopathy patients is diabetic macular edema. The following are the requirements of a diabetic retinopathy screening program: identification of the population at risk, an efficient register and recall system, an effective instrument for viewing the retina, an experienced interpreter of the findings, a screening protocol, a system for managing the cases identified, feedback to the screening personnel, and quality control. From the question asked, the following are important points to note. I've been given a task to set up a screening program for diabetic retinopathy, and to achieve these tasks, this will require planning. And planning for what? Diabetic retinopathy screening. Where? In my state or province. And my state at the moment is Plateau State. An effective diabetic retinopathy screening depends on collaboration between major stakeholders led by an ophthalmologist. And this is achievable through workshops where experience and expertise of participants can be used to plan efficient and effective diabetic retinopathy screening program. So I'll begin with advocacy, which is an important step in setting up screening program for diabetic retinopathy. There is a need to engage governors, critical stakeholders on the burden of diabetic retinopathy and the need for a screening program. The Plateau Ministry of Health will be involved. Partnership with the Plateau State Eye Care Team. This is very important because at the various healthcare facilities, I would have members, individuals I could collaborate with. And I also like to collaborate with endocrinologists, diabetologists, because these are individuals that see diabetic patients frequently, and they could be they could be an important source of contacts to these diabetic patients. Obstetricians that see women with gestational diabetes, pharmacists, non-governmental organizations, philanthropists, because I'll be in need of financial assistance. I may like to get more facilities. So I'll need to partner with these individuals. I also need to collaborate with the community heads, because I would like to involve the community in this screening program. Service group, the media team, and other stakeholders in setting up this program. In planning for this program, I need to know where we are now, where we would like to be, and how to get there. And I'll begin by carrying out need assessments. Plateau State has a population of approximately 4.2 million as at 2016. And this was projected from the 2006 population census. There are 17 local government areas in Plateau State, 3 senatorial zones, the northern, central, and southern senatorial zones. The entire state consists of 940 primary healthcare facilities, 59 secondary healthcare facilities, 2 tertiary healthcare facilities, and this was obtained from the Plateau State Health Development Plan as of 2015. Mapping is required to identify the location and the pathways to these various health facilities. I also like to obtain data in order to estimate the magnitude of diabetes mellitus and diabetic retinopathy. And this data will be obtained from population-based studies, rapid assessment of avoidable blindness, diabetic registers held by diabetologists, local diabetes advisory group, or health authorities, laboratory registers, general practitioners disease register, hospital diabetic clinic records, pharmacy prescription for diabetic preparation, and also by direct advertisement to the public. I would like to identify the risk factors for progression of diabetic retinopathy, which includes hyperglycemia, duration of diabetes, hypertension, proteinuria, hyperlipidemia, racial and genetic factors, cigarette smoking, and pregnancy. Important considerations include who to screen, when to screen, who does the screening, how to screen, when to refer for treatment, follow-up system, who follows up, and when should screening stop. From the national guidelines on diabetic retinopathy, I was able to obtain these findings on need assessment for diabetic retinopathy screening in Nigeria. And the population to be covered was the age group of 20 years and above. And this was, most of these figures here were estimated by the International Diabetes Federation. And this document showed the number of people living with diabetes mellitus that needs examination of the retina in 1 to 2 years, number of people living with diabetes mellitus with diabetic retinopathy, number of people with vision-threatening diabetic retinopathy. I would have loved to use these documents to estimate, to make some estimations in Plateau states, which would have been an important one for me because it included individuals ages 20 years and above. And this will cover up for individuals with type 1 and type 2 diabetes. But because these were estimated figures, I would like to make use of the National Nigerian Blindness and Visual Impairment Survey findings, and which are as follows. The prevalence of diabetes mellitus was given as 3.3%. 48% of people with diabetes did not know they had diabetes. 20.5% of diabetics had diabetic retinopathy. Sight-threatening diabetic retinopathy was found in 10% of diabetes. Higher prevalence of diabetes was associated with urban residents, obesity, overweight, and sedentary lifestyle, and 30% of non-insulin dependent diabetes mellitus had diabetic retinopathy at diagnosis. So for my need assessment in Plateau State, using the population of approximately 4.2 million, the number of adults ages greater or equal to 40 years and above was obtained to be 840,088. Using the National Nigerian Blindness and Visual Impairment Survey, 20% of the entire populations were adults, ages greater or equal to 40 years. So I used this figure to calculate the number of adults in Plateau states greater or equal to 40 years. So I also calculated the number of diabetics in the population of adults greater or equal to 40 years in Plateau states, and it was 27,723 adults. And it was calculated using the prevalence obtained from the National Nigerian Blindness and Visual Impairment Survey using 3.3%. So, and I obtained 27,723 adults greater or equal to 40 years in Plateau states with diabetics. Population of adults greater or equal to 40 years with diabetic retinopathy was estimated to be 5,000, was calculated to be 5,683 adults. So I would like to analyze resources and utilization Human resources. How many general ophthalmologists do we need in the Plateau State? The population of Plateau State, as I said initially, was about 4.2% as of 2016 on estimation. And according to the World Health Organization, we need 4 ophthalmologists per million population. So from my calculation, I was able to see that about 17 ophthalmologists are needed to offer services to the entire population in Plateau State. How many endocrinologists do we have? How many diabetologists? How many supporting staffs in terms of such as optometrists, ophthalmic nurses, technicians, primary health workers? So from the World Health Organization standard, we know that 10 optometrists per million population is required. So for the population of Plateau State, about 42 optometrists are required. For the ophthalmic nurses, we need 42 ophthalmic nurses. And the primary health workers, about 840 is required. Based on the WHO, about 200 primary health workers per million population is what is needed. And on in Plateau States, we require 840. So, and I also like to know how many vitreoretinal surgeons we have and how many medical retinal specialists. Looking at the healthcare facilities, in Plateau State, we have now around 40 primary healthcare facilities, 59 secondary, 2 tertiary healthcare facilities. These are important because I should be able to mobilize the healthcare workers at these various healthcare centers. And I would need their collaboration to carry out this diabetic retinopathy screening. So I also like to know about the availability of health facilities and their utilization, such as the theaters, laser facilities, vitreoretinal machine, fundus camera, non-mydriatic cameras. I would like to also know about the presence of other eye care programs. I would like to access available services. I would like to know the access to the available services by the review of records that have been made. The level of community involvement in assessing and uptake of diabetic retinopathy care services and the likely barriers. Screening materials in various healthcare facilities. It's important to know at the primary healthcare facility, there should be visual acuity charts, Snelling's chart or Logma charts, and the near charts. Presence of a pinhole, they should have at least direct ophthalmoscope in the secondary healthcare facility and even the tertiary healthcare facility. They should have binocular indirect ophthalmoscope, slit lamp biomicroscope with wide angle lens, conventional fundus camera, or smartphones with adapter for fundus photograph, digital retina imaging with non-mydriatic camera, which is the ideal. So some of these facilities should be at the primary healthcare facility. Others are the secondary and tertiary healthcare facilities. There should be computers, internet access, and data storage for transmission of images that are captured during the diabetic retinopathy screening. There should be a reliable power supply. So all these will be required for me to analyze resources and their utilization in the various centers. It's important to note that the instruments for taking these fundus photographs, they have their various sensitivities and specificities. And because their sensitivities and because the quality of image produced by these instruments, they are very important. Of course, there will be differences in the cost of obtaining these instruments. And so I would also like to note the various instruments that are available, and even the screeners in terms of the human resources, the screeners, the graders, and those who will be making use of these facilities. I would like to know whether they are available or they would require more training. All these will be analyzed. And so on this page, I have the various sensitivity and specificity for the various instruments that could be in use. A systematic review of artificial intelligence performance in diabetic retinopathy screening demonstrates these technologies have high sensitivity, as high as 87% to 95.2%, but generally has a low specificity. The sensitivity of detection of any diabetic retinopathy by digital imaging was 92%, and specificity was for diabetic retinopathy was 96%. The predictive value of negative test was 94% and positive test 95%. So for sight-threatening retinopathy, digital imaging had sensitivity of about 100%. The sensitivity of direct ophthalmoscope for diabetic retinopathy was found to be 37.63% for non-sight-threatening diabetic retinopathy, 68.25% for sight-threatening diabetic retinopathy, and specificity for direct ophthalmoscope was found to be 71.2% for both non-sight-threatening diabetic retinopathy and 90% for sight-threatening diabetic retinopathy. Screening personnel include ophthalmologists, diabetologists, general practitioners, clinical assistants, optometrists, technicians. Now, I would like to have an aim to reduce avoidable blindness from diabetic retinopathy by 50% in plateau state over a 5-year period. And I would like to set my objectives, which should be SMART. They include to identify the presence of diabetes mellitus in plateau states, to identify the presence of diabetic retinopathy in plateau states, to provide health education services on diabetic retinopathy in plateau state over a 5-year period, to train 25 graders of diabetic retinopathy in plateau states over 5 years period. So my priorities and strategies, they include health education, screening of diabetic patients for diabetic retinopathy in endocrinology clinic, routine screening of diabetic patients according to the simplified international classification of ophthalmology in ophthalmology clinic, screening in the community and referral to the nearest tertiary center for diabetic retinopathy treatment services, and screening in the community to provide tele-ophthalmology services in communities to screen and refer fundal images by trained graders, then plan for an intervention at the closest facility. Use of artificial intelligence for screening of diabetic patients, home monitoring of patients having diabetes mellitus with handheld ophthalmoscope. So now the screening protocol will go this way. So the diabetic retinopathy screening will include documentation of recent blood glucose, blood pressure, lipid profile, poor glucose control in diabetes. And this should be done even at the primary healthcare level. Visual acuity testing and retinal examination. And a screener must be trained to take retinal photograph or a trained person to determine presence or severity of diabetic retinopathy. Telemedicine approach, which is connected to a diabetic retinopathy grading hub, would also be required, and feedback needs to get back to the patient within 7 days, or the use of artificial intelligence grading system would also be of assistance. A screen-negative individual does not have any form of diabetic retinopathy or has mild non-proliferative diabetic retinopathy. While a screen-positive individual is one who has moderate non-proliferative diabetic retinopathy, severe non-proliferative diabetic retinopathy, proliferative diabetic retinopathy, or any form of diabetic macular edema. So, and this is what will be used as a screening protocol in the course of the diabetic retinopathy screening program. So for patients that have no abnormalities, there's no apparent non-proliferative diabetic retinopathy, those patients will be rescreened in 1 year. For mild non-proliferative diabetic retinopathy, in which there are microaneurysm only, the patient will be rescreened in 1 year. And for moderate non-proliferative diabetic retinopathies, where there are microaneurysms and other signs of blood hemorrhages, hard exudates, cotton wool spots, they will be referred to the ophthalmologist within 1 month. So for at the primary healthcare level, these individuals could be referred to the secondary healthcare facilities within their senatorial zone. And if these secondary healthcare facilities do not have ophthalmologists present in them, they can also refer to other secondary healthcare facilities or even tertiary healthcare facilities in their zone. For severe non-proliferative diabetic retinopathy, moderate, which include clinical findings of intraretinal microvascular aneurysm in at least one quadrant, and venous bleeding in at least 2 quadrants, they need to refer to also an ophthalmologist within 1 month. Then for cases of proliferative diabetic retinopathy, the action recommended is a fast-track referral to the ophthalmologist. So the referral system will be between the primary healthcare centers, secondary healthcare centers, and tertiary healthcare centers. So there's also a screening protocol by there's also a grading system by the International Classification of Diabetic Macular Edema on diabetic macular edema. So on examination, as I mentioned earlier on, there are retinal fundus and imaging system that could be used. And for patients with no macular edema, the patient will have to be rescreened in 1 year. And for patients with non-central involving diabetic macular edema, the patient will be referred to an ophthalmologist. And for central involving diabetic macular edema, fast-track referral to the ophthalmologist will be required. So for the referral system, for diabetic retinopathy screening, this will follow this illustration as stated here. So for the primary health care center, the history will be taken and some documentations, tests, as I explained earlier on, the blood glucose level of the patient that is being referred, the blood pressure, the lipid profile, all these will be documented, and the findings. So if there are screeners or graders that have been trained, they can take photographs, fundal photographs, and grade the patients appropriately and refer. But for cases where the graders or screeners have not been trained, they can take photographs and send these photographs to be interpreted by ophthalmologists or a trained specialist. And on receiving a feedback information, they can as well refer patients from their primary healthcare facility to secondary healthcare facility within their senatorial zone. And if they don't have facilities for that, they refer to other secondary healthcare facilities or tertiary healthcare facilities that can ensure that these patients that have been screened are being treated and followed up appropriately. And a feedback system will be required to all facilities that have made referral. Patients in low-risk categories, for example, those who are 70 years at diagnosis, with no diabetic retinopathy at first screening. So such people are required as low-risk categories. They may eventually be screened the following year. And then children under 12 years may be screened every 2 years. Decisions to extend interval beyond a year should be taken by the screener or the doctor. Then patients in high-risk categories, such as pregnant patients or patients with episodes of ketoacidosis, they need to be screened at 3 monthly interval. Young insulin-dependent patients may wait for 2 years before screening, and type 1 diabetes should be screened within 5 years of diagnosis. All non-insulin-dependent patients should be screened for the first time as soon as they are diagnosed, because duration of disease is unknown, and screening should be done yearly after diagnosis. So some protocols may allow treated patients to be returned to routine screening, but this depends on the experience of the screeners. Adequate arrangements should be made for treatment of cases identified, and there may be a backlog of untreated cases before a steady state is reached. So the issues that may arise are availability of equipment and maintenance of trained personnel. A feedback to the screeners on the outcome of their referral will also be necessary. And this helps to maintain interest and motivation, as screening in isolation is unrewarding. So I would also like to set a target and timetable for this program to screen 500 diabetes mellitus patients within the first year, and then to increase to about 25,000 by 5 years. Laser or intravitreal antivascular endothelial growth factors injections would also be provided and administered to about 100 diabetic retinopathy patients in the first year, and this would increase by 1,000 in the next 5 years. Surgeries, vitreoretinal surgery for advanced disease. This will involve carrying out surgeries on about 20 diabetic retinopathy patients within a year, and then to increase to 100 by 5 years. So all these are my targets, and I would also like to have an output indicator. I would like to have output indicators for all these targets, such that they will be reviewed either quarterly or annually. So all the various activities that are taking place at the primary healthcare level, there should be reports that are being taken and sent to the senatorial zone coordinators. And this should be done 2 weekly or monthly. And then quarterly, there should be reports. There should be a report even sent to the stakeholders, so that they are aware of the activities that are taking place, and we can carry them along, and they are sure that our targets are being met. So this table shows a list of activities, such as dilated fundoscopy, treatments in form of surgery, medical treatments, and surgical treatments. Their output indicators include number of people that are being treated by the required manpower, the ophthalmologists. The graders will also give I will also get the output indicators from the graders, the number of people that are being screened and the number of people referred to the various referral centers. So the same for the optometrists, the number of diabetics that have been seen by them and those that were screened and referred. The endocrinologists, they see diabetic patients frequently. I can also get a feedback report from them. So I also like to have a project implementation plan. And this is just like a guide on a plan made as written. I'll have a list of activities, the project time period, and then the resources needed and the persons that will be available or responsible for these activities. So, and I also need to manage resources because manpower is involved. There will also be need to pay salaries or make payments to individuals that are involved in these screening activities. And there will be need for equipment. So the equipment that are being purchased and those that are required, I would like to make a budget and state them appropriately. The cost of transportation by all these screeners and graders, all these will be needed, and even by the ophthalmologists. The budgets on the various facilities that are being used in this diabetic screening program. So the feeding, because human resources are involved, they need to be fed. All these budgets would be stated. There's also a need for quality control. A sample of patients may be rescreened by an assessor and may be difficult as patients may be unwilling to be screened twice and may undermine their perception of screeners' competence. So an audit is practicable, which shows the number of appropriate referral, number of false positive, those who have spontaneously regressed and referred inappropriately, such as those with macular degeneration, drusen's. These may be transferred back to the screening pool. The number with advanced diabetic eye disease will also be tested for sensitivity of the screening method. Monitoring to track program progress will also be done. Submission of monthly reports on the number of screened and treated patients, the number of those that were screened in the community, those screened in the hospital. All these reports will be collected and for monitoring. The outcome will also be required in terms of the prevalence of diabetic retinopathy, the number of people trained for grading. Then there will be impact indicators like the percentage reduction of avoidable blindness after 5 years. So, and this evaluation will also be required, and this will help to improve on the program at the beginning, in the process, and at the end of the program. The screening program is hoped to eliminate avoidable cause of blindness from diabetic retinopathy in Plateau State by 50% at the end of 5 years. These are my references. Thank you.
Mashor, very detailed presentation. Can you hear me? Hello, well, what do you mean? Hello.
Hello, Dr. Idris, we can hear you.
Okay. Yeah. All right. It was a very elaborate presentation. Thank you so much. Gained a lot. We'll use the few minutes left to take questions and comments. And also drop questions into the chat box.